Hi, welcome and good evening. My name is Liam Moore. I'm a staff member here at the American Brain Foundation, and I'm very much looking forward to tonight's program with Dr. Maisha Robinson. First, I want to introduce our host for the evening, Dr. Lisa Shulman. Dr. Shulman is a neurologist specializing in Parkinson's disease and other movement disorders. In addition to neurology, her diverse background includes training in health policy, nursing, and education. She is the Eugenia Brin Professor of Parkinson's Disease and Movement Disorders and the Rosalind Newman Distinguished Scholar in Parkinson's Disease. She is a former American Brain Foundation board member and currently serves on our Ambassadors Council. Dr. Shulman is the author of the book Before and After Loss, a neurologist's perspective on loss, grief, and our brain. And she graciously hosted our most enduringly popular webinar way back in 2021, Healing the Brain After Loss, which you can find on our YouTube channel. Dr. Shulman, thank you for being here.
Well, thank you very much, Liam, and it's a pleasure to be with you. Welcome, everybody. So tonight we'll be learning about maximizing quality of life at the end of life. And before I introduce our speaker and tell you a little bit of the important things about the hour we'll spend together, I just wanted to reflect on this topic that when I trained in medicine in the 1980s, I'm not sure that there was ever even a word about end-of-life care. And maybe our speaker, Dr. Robinson, may want to comment on it, whether that's changed or not. I'm not even sure myself. But the fact is that there was really no course, there was really no section, no attention to the topic. And, as a result, many physicians still find it to be an area of challenge. And, I think part of it is that it's not at all easy to learn how to diagnose and treat illness. And so people who train in medicine are working so hard to do that, that they are so focused on it, it can be difficult, even with people who are becoming more and more advanced in whatever condition they have, to switch gears and begin to talk about end-of-life issues. And in my experience, our patients and family members sometimes have the same exact orientation, that they become so accustomed to talking about their symptoms and what needs to be treated, that there is the same hurdle to overcome, to pivot, as I think of it, to talk about end of life. I look forward to hearing Dr. Robinson's thoughts on that. So some of the important things for tonight is that, as many of you know, these webinar events that the ABF, American Brain Foundation, hosts are opportunities to connect all of you with experts in various topics of interest about the brain. And I want you to think about, as you hear about the different issues that are raised tonight, to put your questions in the chat. And after the presentation, we'll try to address as many of those questions as we can during the Q&A. The American Brain Foundation funds research very uniquely across the entire spectrum of the brain, knowing that brain diseases and injuries and different kinds of disorders are actually more interconnected than you would realize. Importantly and appropriately, the ABF is currently funding research that involves end-of-life care, which is really to their credit. And they're looking at right now a project, or funding a project, that explores end-of-life disparities of care among diverse populations. It happens to be with Parkinson's disease in my own area of interest. Now, the ABF cannot exist without support from donors. And if you are so moved, please consider a donation so that we can continue funding critical research and continue to host these free webinars like tonight. You can give at americanbrainfoundation.org/donate, or you can scan the QR code that's right on the screen right now. Okay, so let's move on to tonight's program. The topic being maximizing quality of life at the end of life, with our guest, Dr. Maisha Robinson. Dr. Robinson is an assistant professor at the Department of Neurology at Mayo Clinic in Florida. with a joint appointment in the Department of Internal Medicine. Upon joining Mayo Clinic staff, she established the clinic's first neuropalliative care program, and she currently serves as the division chair of palliative medicine at the Mayo Clinic. Dr. Robinson has spoken nationally and internationally on neuropalliative care. She edited a book titled Case Studies in Neuropalliative Care, and she's a member of the American Board of Internal Medicine Approval Committee on Hospice and Palliative Medicine. She's also very active with the American Academy of Neurology and currently serves as the chair of the Member Engagement Committee and an ex officio member of the Board of Directors. So thank you, Dr. Robinson. We're really looking forward to hearing what you have to say.
Thank you. So, I hear it sometimes from colleagues, Dr. Robinson, I was thinking about putting in a palliative care consult, but I didn't want my patient to think I was giving up on her. Mm-hmm. Or sometimes a caregiver of a patient I'm taking care of will say, Dr. Robinson, we were wondering if palliative care was appropriate, but, then dad might think that we knew something he doesn't know. So I want to talk a little about maximizing quality of life at the end of life, specifically in brain disease. So when I think about palliative medicine, I think about a specialty of medicine that actually aims to recognize, prevent, and alleviate suffering of all forms: physical, spiritual, psychological, and social. And many times when people think about palliative care, they only think about end-of-life care. But I will say that we focus on things earlier than the end of life as well. We're thinking about symptom management. We're thinking about caregiver support. We're thinking about coordination of care. We're thinking about nutrition, how are finances being impacted by this disease. So we're thinking about a whole range of things. And it's really a whole person approach to care and whole family approach to care, I would say. And it's appropriate at any stage and at any age of a serious or advanced neurologic condition, independent of whether the goal is maximizing quality of life or really just focusing on even cure. So when I talk a little bit about the spectrum of palliative care, Dr. Shulman mentioned she trained in the 80s. I trained in the late 2000s. And when I started neurology residency, there also wasn't discussion of palliative medicine. I was the person that was calling saying, hurry, hurry, hurry. I have somebody that looks like they may be dying. What am I supposed to do? I wasn't comfortable with it. I didn't know how to navigate end-of-life care. What I know now, though, is that there's a role for palliative care at the time of diagnosis, time of a neurologic diagnosis, all the way through the disease and at the end of life. And what you'll see on this diagram here is really the spectrum. So you see diagnosis all the way to death. And even after death, you'll see there's still a role for palliative care in the form of hospice care. Now, many people tend to equate palliative care with hospice care, but I tend to think about it as an umbrella term. Palliative care is the umbrella, and underneath that, there's hospice care. So hospice is a type of palliative care. All hospice care is palliative care, but all palliative care is not hospice care. Hospice is really appropriate for people who are at the end of life with likely 6 months or less to live if the disease continues in its normal fashion. So over the last couple of decades, there's been a significant rise in palliative care programs in the United States. Normally, I ask people to turn off their microphone and tell me why they think this is. But tonight, I'm going to spare you, and I'm just going to tell you why. So a couple things. Number one, people are learning there is benefit to palliative care, so people are asking for it. Number two, people are being treated for chronic diseases longer. They're living longer. There's a larger role for palliative care. Number three, physicians and hospital systems are recognizing there is value in having palliative care teams. So this cartoon says, there's no easy way I can tell you this. So I'm sending you to someone who can. And many times people think about palliative care like that. You know, I'm taking care of somebody. It's like they're getting close to the end of life. I'm not comfortable with that. I'm going to ask you, Dr. Robinson, to see them in palliative medicine or one of your colleagues. But the way I think about this is just a specialized field of medicine that really focuses on the whole person, symptom management, caregiver support, thinking about big picture goals, and then also talking about some of the tougher things, including end of life care. So I'll tell you, all of your physicians, all of your clinicians are doing some degree of palliative care. They may not call themselves a palliative care physician or nurse practitioner or physician assistant, but everybody's doing palliative care. All the neurologists, all your primary care doctors, all your family medicine doctors are doing some palliative care. All of us are trying to figure out, how do we manage symptoms? How do we deal with some anxiety or depression? How do we talk about the big picture? Where is this disease going? What do we know about life expectancy? All of us are talking about how we can alleviate suffering. The field that I'm in, palliative care, is really specialized, and we focus on some of the more complex issues. There are not enough palliative care specialists for everyone who needs one to see one. Therefore, we rely on a lot of the primary care doctors or the primary teams, the neurology teams, perhaps in the hospital, to provide that palliative care. Then there are specialty palliative care teams available as needed. So many times people wonder, sort of, what all do you cover? When people are at the end of life, we still cover all these things because we want to make sure that we're treating the whole person and the whole family. So structure and process of care is really about, do you understand what the disease is? Does anybody have a good feeling in terms of what's going to happen in the family with regard to the trajectory of this disease? We also explain what palliative care is and what hospice is to make sure we're speaking in the same language. Physical aspects of care has to do with, what are the symptoms? Are you having difficulty with tremor? Are you having some constipation? Are you having pain? Are there difficulties getting your words out or swallowing? What are the symptoms that are causing the most trouble right now? Social aspects of care has to do with, who is your support system? Who's helping you get through this difficult time? Psychological and psychiatric aspects of care has to do with, how are you coping? Tell me about what has happened in the past that has been difficult to deal with. And what did you use to get over that hump? Is that helping you now? Spiritual aspects of care, not so much about, are you religious or spiritual, but, what gives you meaning? What gets you up every day despite what's going on? Cultural aspects of care are the things that we should know about you to take the best possible care of you, things that we may not see in the medical record. Ethical and legal aspects of care has to do with, if you can make medical decisions for yourself, who would help you make them? And what kind of medical care do you want specifically at the end of life? And then when people get to the end of life, we focus on making sure that the care is of highest quality. So I'm going to walk you through 2 cases of patients that I've taken care of and just show you a little bit about the role of palliative care as they got closer to the end of life. So a 53-year-old gentleman that I saw had a history of high blood pressure. I saw him because he had lung cancer that had metastasized to the lining of the brain, leptomeninges. He also had some disease in the bone and also in the adrenal gland. He was being seen by oncology and neuro-oncology because of the brain disease. And I was asked to see him to help with symptoms, to help with sort of goals of care, and to provide some support for his family. When I first saw him, he came into the office in a wheelchair, very fatigued, had very poor appetite. He couldn't really walk well, which is why he was in the wheelchair. And his mother and twin brother who were with him just said he's so confused. He really can't even get words out. They looked at me and said, Dr. Robinson, he is not the man that we know. He is a brilliant engineer, multiple patents to his name. And right now, we can't even understand him trying to ask us for basic needs. And I asked them, what are you hoping for? And they said, we're hoping that this treatment that he's on will get the cancer under control. We're hoping that his quality of life will be better. His twin brother had moved in with the mom along with him to really provide as much support as possible. And so those were the people who were closest to him. And I asked them, what worries you the most? And they said, what if the treatments don't work? So I started seeing him very early in the disease course. Months 1 and 2, he was undergoing chemotherapy and he got whole brain radiation therapy And when I saw him, he was fatigued, as I mentioned. So I was trying to help with that. He was constipated because of some of the medicines he was on. His appetite was low. And so I was really trying to see how could we try to help him feel a little bit better. By month 3, he had developed some side effects from the radiation therapy. He now had a dry mouth as well, and he had some nausea. So we were helping to manage that. By month 4, he had improved some from the radiation symptoms, and the medicines we were giving him were working some. He was still on chemotherapy and was feeling a bit weak. By month 5, he was walking into the office, actually, and felt much better. He was able to engage with me, and he was able to sort of tell me how he was feeling, weren't relying so much on his twin brother and his mother. He was still symptomatic, though. By month 6, he was walking in independently to the office, and I was able to engage him fully in a conversation. I took that opportunity to really talk with him about who he would want to make medical decisions for him if he couldn't make them for himself, and to really outline what kind of medical care he wanted at the end of life. He said to me, I'm hoping that things continue on this trajectory. I'm hoping that I continue to feel as good as I do now. I'm hoping that the cancer will remain at bay, but they're telling me that it's going to come back. And when it does, and I get close to the end of life, I don't want to die in a hospital. I don't want to be in a debilitated state. I want to really have the best quality of life I can when I get there. And I talked a little about hospice care, and he said, I would be open to that at that time. Let me tell you just about a quick study done by a lung cancer doctor at MGH Hospital. She was interested in how people would do if they got palliative care early at the time of diagnosis from lung cancer versus if they got it some other time along their disease course. So she randomized her patients, 151 of them, to either usual lung cancer treatment or usual lung cancer treatment plus palliative care at the time of diagnosis. And what they found was that in this group that got palliative care at the time of diagnosis, the quality of life was better. Mood was better. There was more documentation of whether they would want CPR or not. That's no surprise. I said we sort of talk about all those types of things in a palliative care consult. They were less likely to die in hospitals and in an intensive care unit and to be back and forth to the emergency department. But what was interesting is that these patients actually survived about 2.7 months longer than the patients who had the usual lung cancer care. And what's interesting about this is that many people equate palliative care with expedited death. But this sort of shifted our mind some, both the oncology field and the palliative care field, to think about we can really improve the quality of life for people until the end of their lives. And so now the recommendation is really to incorporate palliative care at the time of diagnosis, include it all the way through the journey in people that have cancer, including brain cancer, and then continuing to make sure that we're treating symptoms at the end of life. The second lady I'd like to share with you is 91 years old. She has hypertension, diabetes, atrial fibrillation, and some mild dementia. I was asked to see her after she had a stroke on the left side of her brain. She had gotten the clot buster medication, TPA, and then she had bled a little bit as well after getting that. They wanted me to see her to discuss big picture goals of care and to talk about how she could get her nutrition because she wasn't able to swallow. So when I met her daughters were at the bedside and they said, Mom is 91. She has a little bit of dementia, but I'm telling you, she was functioning very well before this. I mean, she was doing almost everything independently at home, bathing, going to the bathroom, dressing, eating on her own. They said our brother was living with her, but it was sort of convenience thing for him too. He was helping with some meal preparation and medications, but that's about all. Mom was doing well. And they said, over the years, she had always told us she never wanted a feeding tube. She always said she wouldn't want to be resuscitated. If her heart stopped, just let her go peacefully. But they said, Dr. Robinson, she didn't say if I have a stroke, don't put a feeding tube in. She didn't say if I have a stroke, don't resuscitate me. So they weren't sure what to do, particularly regarding the feeding piece. And I said, well, if she were so clear about what she wanted, I'm sure she wrote this down. Does she have an advance directive? And they said, Mom never wrote it down. So I practice in the state of Florida. These default orders of healthcare decision makers tends to be state dependent. So if the person can make his or her own decision, we ask them. Our patients make their own decisions. If they cannot and they've designated somebody, the healthcare surrogate, or in other states you may call them the healthcare power of attorney or healthcare proxy, those tend to be the designated decision makers. In the state of Florida, we use the proxy term as the default order for people who don't have a specific listed healthcare decision maker. In the state of Florida, for instance, if you have a spouse, it automatically goes to your spouse. Even if you're separated for 30 years, your spouse is still the decision maker. Spouse, then adult child, then from the adult child to the parent, from the parent to the adult sibling to adult relative, any relative you can find. Then we just try to find any friend. And then if we can't find a friend, we send the information to a social worker, another hospital who helps make medical decisions for the patient we're taking care of. So you can see this order. Most people would say, I would rather designate somebody to help me make medical decisions than rely on what the state is going to say with regard to who my decision maker would be. So I'll say for all of you on, if you don't have an advance directive, I would encourage you to do one. At least talk with friend, family member, coworker, colleague. It can be anybody to help you make medical decisions and document it and let them know what your wishes are. I mean, this patient was very clear. She wouldn't want a feeding tube. She didn't want to be resuscitated at the end of life. She told her, but you can see when this episode happened, when the stroke happened, the family wasn't sure what to do. So the daughters decided, we'll put a feeding tube in, and they did that. And then she came back up to the fluoroneurology, and she was very agitated, and she pulled it out. And then they put it back in. And then she all of a sudden started to have a very fast heart rate a little bit later in the day. And then she was having difficulty breathing. And it ended up that she ended up having a blood clot in the lung, a pulmonary embolism. And she couldn't get any medicine for it because she had bled in her brain. And so she couldn't get a blood thinner. And so this became a very challenging situation. In the end, her daughters decided to transition the focus of care to hospice care, to really focus on quality of life at the end of life. Her daughter wrote a blog and gave me permission to share it with you. And I'm going to read an excerpt from it here. It says, many of you know, my mom went home to be with the Lord a few weeks ago. God was merciful and swift in her departure from this earth. However, there were a couple of days where my family, under difficult circumstances, had to make emotional decisions. She said, doctors asked us if mom had a living will or advance directives. The answer was yes, no, well, sort of. We had talked about them plenty over the years, but she never wrote them down. She teased us in, shall we say, a rather stern way to never, ever put her in a nursing home. She told us time and time again she didn't want to be resuscitated or intubated, and she never wanted to live with the feeding tube, but somehow the writing them down part never happened. She goes on to say, we may think we know what a loved one wants, but I have to tell you, when things get dicey, emotions run high, that's when we start second guessing what we've known to be true. That is, unless the ill family member left a specific plan. With a plan, there is no question, no guessing, no guilt. You just follow it. So one of the things that we spend a lot of time doing in palliative medicine with our patients who have neurologic disease is focusing on making sure they have a plan for when they get to the end of life. That's one of the best gifts they can give their family members. And the unique piece about neurologic disease is that it tends to not only impact the body, but many also impact the brain. And therefore, as the disease progresses, people lose the ability to really engage in these sorts of conversations. And we want to make sure that we are providing the kind of care people want at the end of life. And in order to ensure that, we have to ask about it much sooner in the disease process.
Toward Route 35.
So when I think about palliative care in general, there's an improvement in symptom management during the course of the disease and at the end of life. Many people will say, I don't want to be in the hospital at the end of life. I want to be at home with my family. So palliative care can reduce unnecessary hospitalizations, or a palliative approach to care can do that. It can also improve patient and family satisfaction during the disease and at the end of life. and it can reduce prolonged grief and post-traumatic stress disorder among family members after the loved one dies. The other thing that people hesitate to talk about, but it can lower costs in people who are close to the end of life. Some people will say, I don't want to spend all of my money on my condition, on healthcare. I want to give some of that money to my family. I want to leave things in my will. I want my family to be able to benefit. But if these discussions don't happen, then the default tends to be that a lot of money goes to healthcare. And some people want that, but many people don't. And so having some earlier conversations about the end of life can help reduce hospitalizations, procedures that people may or may not want, and things that they may not actually benefit from. Reduce the likelihood of being in the intensive care unit, and also back and forth to the emergency room. Some people would say, just allow me to be home with the support of hospice. Doctors, nurses, social workers, spiritual advisors who can come into the house to make sure that they're providing anticipatory guidance to both the person who's dying and loved ones. Telling them this is what's coming. This is what we anticipate is going to happen. These are the symptoms that we think we may see. And this is how we're going to manage it. Then they also deal with some of the existential distress that may happen as people get closer to the end of life. What does my life mean? What are the next steps for me? People who are spiritual or religious also may have questions. Then they really wrap their arms around the families as well. So in summary, I'll say that palliative care is a specialty that aims to improve quality of life in people that have a serious or advanced medical condition from the time of diagnosis all the way through the end of life, appropriate at any age and at any stage. Most of this is done by your primary care team or your primary physician, your neurologist. In some instances, a palliative care team, a specialty palliative care team, will be involved in helping you think about some of these more challenging decisions that may have to be made, like a feeding tube in the setting of dementia or a tracheostomy in somebody with ALS. And palliative care can improve the overall care for both our patients and families. So this cartoon says, when I die, I want to go peacefully like my grandfather did in his sleep, not screaming like the passengers in his car. A lot of my patients will say to me, Dr. Robinson, one guy said, I want to be at home with a beer in my hand, in my recliner, watching a Philadelphia Eagles game. And I said, I don't know if I can promise you all of that, but what I can promise you is that we're going to take really good care of you when you get to the end of life. Thank you.
Well, thank you very much, Dr. Robinson. That was you covered a lot of territory, and I was scribbling down my own questions, and I hope others were too. So please put your questions in the chat, which I will read out as you put them in. But maybe while you get your questions down, and I really encourage you to do this because, in daily life, we rarely have the opportunity to have these kinds of serious conversations. And if you tuned into this, I'm sure you have thoughts in this area. You're dealing with issues or know you will be at some point. So please tell us what you're thinking. While you're putting your thoughts in, let me start out by asking, you alluded to this in one of your slides, but I think that we oftentimes do see some conflicts between the patient and the spouse, or the patient and the family at end of life in terms of their perspectives. Can you talk about that? And one case I'm thinking of right now is a situation where the spouse is more reluctant to be thinking about end of life than the patient.
Yeah, I think that's a great question. Oftentimes everybody's trying to protect everybody else. And so family members sometimes don't want to bring anything up because they worry that their loved one is not thinking about end of life. Same thing, the patient doesn't want to bring anything up because they're worried the family members aren't thinking about it. But many times people who are living with neurologic disease have these questions. Dr. Bob Holloway, University of Rochester, says everybody is asking how well and how long. How well can I live with this disease, and how long can I live with this disease? And so many times we're just trying to normalize it. So, are you thinking about advanced care planning? Are you thinking about what this trajectory may look like? And when I see people actually for the first time, I'll draw out, depending on the disease that they have, what the typical course looks like if they're interested in knowing. So we open it up at the beginning, we normalize it at the beginning, and that allows some of that conversation to flow over the course of visits. The other thing sometimes I'll do is I'll ask, how are you managing all this? How are you impacted by the fact that you're watching him struggle with this disease or navigate this disease? Sometimes that opens up. So asking some open-ended questions sometimes will bring things to the forefront, or just calling it out. It seems like you are prepared for what's going to happen. I sense a little bit of concern, hesitation, which is completely understandable from you. Tell me about it.
Well, thank you. We're beginning to get some really good questions. And the first two questions, I think, are a little related. I'm going to tell you both of them at the same time. The first one is palliative care appropriate for an elderly person with dementia? And the second one is, what are differences in palliative care between dementia-like illness and medical issues like cancer?
Excellent questions. Let me tackle the first one first. Yes, very appropriate in a situation with dementia. And the reason it's so appropriate is because dementia tends to have a trajectory like this in terms of function and quality of life. It'll start here, then there is a slow decline over time. So family members and loved ones can see the decline coming. They're already anticipating the decline, which can cause, anxiety or even anticipatory grief in some loved ones. And so we think about how do we support caregivers through that. But for the person with dementia, there are undoubted episodes that are going to occur. When there's trouble with swallowing, we need to discuss what's the plan going to be. Do we talk about feeding tubes? And just for the record, neurologists tend not to recommend feeding tubes when people have advanced dementia. It doesn't tend to improve quality of life or prolong life, but can cause more agitation or distress for people who have dementia. So that's a big conversation. The other things we tend to talk about are when is it time to transition to maybe another living facility, or what's the plan going to be when more help is needed at home? And we think about end of life. Where do you want to be? What is the plan going to be? Who's going to help you make medical decisions? So all of these sort of key things that are appropriate to talk about earlier in the setting of dementia are covered often by palliative care or can be covered by your own neurologist or neurology team. I would say the difference between neurologic disease and, for instance, cancer that's not affecting the brain would be the cognitive changes that tend to happen. When people have cancer, that doesn't affect the brain, we can often engage with them throughout the whole course of disease. They know what's going on. They are aware of the deterioration. Many times, particularly if people have dementia, large strokes, other brain diseases, they lose some of the awareness of what's going on, or they lose the ability to make medical decisions for themselves. And if we wait too long, we lose the ability to really engage them in those kinds of conversations. So the timing in which we have these discussions tends to differ in people that have neurologic disease. We need to have these conversations earlier, sooner rather than later. Whereas people that have cancer that's not affecting the brain, we tend to have more time to discuss things because they remain aware and engaged in terms of what's going on.
Well, thank you. And, I'm just going to add to that a little bit because I see a lot of patients with dementia. And I think it's important to also not consider dementia as one big thing. As instead, the patients who have different forms of dementia have different areas of strengths and weaknesses. It doesn't mean that they're completely unable to benefit from Dr. Robinson's counseling. It's just that some of it would have to be personalized based on their needs. Well, we are hearing from many people who are saying they really enjoyed your presentation. One, perhaps, I hope it's an easy question, is palliative care fully covered by Medicare?
That's a great question. Usually, palliative care visits are covered the same way general medical visits are covered, neurologists, pulmonologists, cardiologists, et cetera. So yes, usually it's covered. Hospice has a a benefit through Medicare. So there's a Medicare benefit specifically for hospice care, and most even other private insurance companies have a hospice benefit too. So people tend not to take advantage of hospice, but what they don't know is that usually it's already covered by their insurance. Some of the things that, for instance, specifically with hospice may not be covered is if you're in a hospice facility. So if you're not at home, but you've elected or somebody suggests you go to an inpatient facility, oftentimes the room and board may not be covered, although the medical services are covered. So asking this question is important. Is this covered is a good question. But for general palliative care services, usually they're covered the same way that all your other specialists or primary appointments are covered.
Thank you. So Susan asks, this is good. How do you know when to transition from palliative care to hospice?
Great. So that slide I showed is sort of a continuum. Palliative care, remember, it's the umbrella term, has hospice underneath it. So when people are in palliative care, they're not necessarily in hospice care, but anytime you're in hospice care, you're already in palliative care. And so oftentimes, if somebody is following you, your neurologist may say, or your palliative care physician may say, I think we're getting close to the end of life. Certain diseases, and they are limited, but certain diseases have actual suggested guidelines for when to consider transitioning to hospice care. For instance, if somebody has a large stroke and they're not able to eat and they've decided they don't want a feeding tube and they're losing weight or they're having recurrent issues with aspiration, food or liquids going down into the lungs or other infections, or they're back and forth to the hospital, that may suggest that they are in a situation that has a limited life expectancy. And so neurology lags behind some of the other conditions. And so we use a few of the guidelines we have and sort of extrapolate to other neurologic conditions. And I will be honest with you, we're not excellent. We're not excellent at all in knowing when somebody has 6 months or less to live. We're not. But you don't have to actually die in 6 months to be in hospice care. You just have to have a condition where 2 physicians are willing to state they would not be surprised if you did not survive for 6 months. So I think when you're getting close to the end of life, recurrent hospitalizations, infections, weight loss, for ALS, for instance, declining breathing, and you've elected not to have advanced breathing like being on a ventilator, you may consider transitioning to hospice care.
Okay, so I misspoke, and that was a question from one of the listeners named Lisa, and this is from Susan. What happens if the designated person in the advance directive fails to make a decision?
That's a great question. Oftentimes, if the person that is named cannot make a decision, it moves on to either the alternate healthcare surrogate, which may actually be listed, or the state goes by the default order. So for instance, most places, if the spouse is the person listed on somebody's advance directive and they can't make the decision, or they're not willing to make the decision, then it goes to whomever would be the next in line to help make the medical decision.
Thank you. Another question about insurance is what happens with those who are on Medicaid?
Great question. Oftentimes, hospice will accept people even who are on Medicaid as well. So it tends not to be a barrier for hospice care. Even I'll say there are many hospices that people are uninsured, that some hospices will provide care even as charity work. So if you're taking care of people or you know people that have minimal insurance or no insurance, I would suggest still contacting the local hospice agency and saying, are you all open to providing end-of-life care?
Okay, this is a bit of a long question, so bear with me while I read it out. Can you speak to the words that you use to convey the progression and what is to be expected? For example, people don't starve at end of life. They cycle down in their intake. They don't forget how to eat. The brain is no longer telling the body that it's hungry. The words we use cause even more problems. So often people think a food source will prolong life.
So I'll say, Susan, this is a really good question, and we spend a lot of time. I live in the South. I'm in Florida, so everything is about food, and a lot of it's not healthy food, but everything's about food, and everybody's worried about loved ones starving to death. I think you are actually explaining it quite well. I often say to people that as people get to the end of life, the body starts to shut down. And so if we are giving artificial nutrition and fluids to people, what you tend to see is that the body doesn't know what to do with it. And I ask people often, have you ever seen somebody nearing the end of life that is very swollen? And a lot of people actually have seen that. Or you touch the skin of somebody dying and it's wet, they're weeping. I tell people when the fluids are going in or this nutrition is going in, the kidneys are starting to shut down. The gut, the intestine is not working anymore. They're not processing food like we are. And the liquids have to go somewhere. And they often come out into the skin or into the tissues and they seep out. Most people go, oh my goodness, we don't want that. And I'll say sometimes it can also go into the lung. People have seen people at the end of life that are struggling to breathe. They have fluid on the lung. And that can come from that. So I used to say to people, we suggest doing what we call comfort feeding with a known risk of aspiration. So if somebody's hungry, we always offer food to people. We never, quote unquote, starve them. Always offer food. And if people are hungry, they will open their mouths and take it. If they're not hungry, they won't. And you're absolutely correct that the same signals that we get to suggest that we're hungry when we're relatively healthy are not the same signals that people are getting at the end of life. They don't experience hunger like we do. And so one of the things I tend to tell people sooner rather than later is that there will come a time when we're getting to the end of life where this nutrition and this fluid that's hanging now will not be helpful. And I will recommend then that we stop. So I try to prepare people for what is coming down the line.
Okay. Why are physicians so reluctant to refer to palliative and hospice?
Well, I think, the way we're trained interferes with this. We're trained to cure. We're trained to, quote unquote, treat. And I think a lot of us feel like we're giving up on people if we think about palliative care or hospice care. We feel like we failed our patients and their loved ones. And so we don't often think about it until it's inevitable. People are already dying before they get into hospice care versus thinking about all the support they could get within months of getting those services. And so this is a long journey that many of us in palliative care have taken to not only educate our patients and their loved ones, but also educate our colleagues about the benefits of palliative care. I will say that one of the things that we have seen over the past couple of decades is a significant decline in feeding tubes in people who have dementia. That's been one of the, I think, successes of palliative care. The other thing we see is palliative care is often integrated into ALS clinics across the country. I think that's one of the successes. Trying to figure out how to normalize the engagement of palliative care or a palliative approach to care has been something that we've tried to do. And I think things are improving. We now have a number of physicians specializing in palliative care in neurology. We have an international society that's aiming to also provide some education. But I think just historically, we have not been trained to think about end of life or to think about how to anticipate it, how to provide care, how to talk about it in a normalized way.
I want to follow up on that question and kind of harken back to the first remarks that I made because there is this pivot that we're talking about between very active diagnostic work, diagnostic testing, and management to starting to think more about keeping the patient comfortable. But I want to drill down into that in terms of, I think some of our patients and family members are concerned that it's either one or the other. That if they say that they're going to be interested in or want to consider palliative care and hospice, that the diagnostic testing and management and treatment would cease. Is that true or not?
Absolutely true. And, one of the reasons I shared that first patient case with you about the gentleman who had cancer that went to the brain, he was getting palliative care while he was still getting chemotherapy. And I think that is very important. And people who are, for instance, having Parkinson's disease, they can still get Botox while they're, or take carbidopa, levodopa while they're still getting palliative care, or they can have deep brain stimulation and still have a focus on palliative care. And so these things can be concurrent. And in fact, they should be concurrent. It should not be, we're switching you over to palliative care. Palliative care is a spectrum of services with doctors, social workers, spiritual advisors, providing support, as I mentioned, for the whole person and the whole family, while you can still get your usual treatment.
I'm not sure I fully understand this question, but the question is, which is one of the procedures of palliative care for dementia?
What I'll just mention, when we think about procedures for palliative care, the conversation is our procedure. Sitting down, trying to get to know somebody. My first visits with everybody, I start off by saying, tell me about you, non-medical. I want to know about you. How'd you grow up? What's important to you? What do you do when you're not working? Tell me about your family. What gives you joy? I'm trying to figure out all these things about somebody so that in time, I can use that to help put some of these more challenging decisions into context. Where you shared with me that this is important to you. If you can no longer do this, what would you do? So we tend to think about the conversation as our procedure in palliative care.
Thank you. How centrally governed is hospice?
Great question. So Centers for Medicare and Medicaid really scrutinize hospice agencies. And they've cracked down recently, I've said in the last 10 years or so, to make sure that the people who are in hospice care are people that really should be in hospice care. There are for-profit hospice agencies and not-for-profit hospice agencies. And just in full transparency, there has been some challenge with some of the for-profit agencies with accepting patients that weren't very close to the end of life and taking money from the government for patients that weren't about to die. A lot of that has changed in the last decade. And so there is an oversight body, although hospices can be sort of privately owned and they can have different for-profit statuses. But I think in general, most hospice agencies are doing a really good job trying to provide excellent care to people that are going through really difficult times in their families.
Hey, here's a guest who's asking you a very specific question. Have you seen a patient with a feeding tube who is under palliative care with a feeding tube who improved, resulting in the feeding tube being removed?
Yes. So it depends on what disease you have with regard to whether a feeding tube is appropriate. I sort of mentioned that we don't encourage it for people who are nearing end of life, who have advanced dementia. Feeding tubes are not suggested in that situation. But many people who have strokes, depending on the size of the stroke and the impact of the stroke, may need a feeding tube as a temporary means of getting nutrition. They need a feeding tube to get more energy to be able to go to rehab and to focus on stroke recovery. And we may see those people in palliative care and have conversations about benefits, risks of feeding tubes, but they may get them. And sometimes we encourage them to get them to aid in sort of that recovery. And then I see them back in clinic and the feeding tube has been removed and as their swallowing improved and their ability to eat improved and their calorie intake improved. So it really depends on what condition. If you have ALS and you get a feeding tube, we would not expect the feeding tube to be removed because we expect things to progress and decline over time. So it depends on the condition. But yes, I have seen in general neurology patients that have feeding tubes that get removed, even those we're seeing in palliative care.
Well, thank you. Because it's a late hour, particularly for those of us on the East Coast, I'm going to, before I tie things up and summarize, I'm going to ask you a tough, provocative question. Are you ready?
Sure.
Okay. Isn't there some data that advanced directives sometimes don't correlate with the views at the end of life?
Yes, that's absolutely correct. And part of it is because it depends on when you do your advance directive. For instance, I am relatively healthy, I think. I have done an advance directive, but did it several years ago. If I develop a serious medical condition, my thoughts might change. If I don't change my advance directive legally, it's going to be the one that I did years ago when I was relatively healthy. So one of the things we encourage people to do is to think about updating or at least reviewing their advance directive if there is, for instance, there are some Ds that we talk about, a death in the family. Sometimes that helps you think through, again, what are my wishes when I get to the end of life? If I have a new diagnosis or a new diagnosis of dementia or ALS or a brain tumor or Parkinson's disease, is what I wrote down still what I want? If I get divorced, particularly if I have my spouse listed as my healthcare surrogate, would I still want that? Another decade. So if I'm a decade older, are my wishes still the same? And a decline. So if there's some decline in my status, should I look at my advance directive again? And so, yes, when people don't sort of review them, they get to the end of life and realize I did that when I was 60 and now I'm 85 and things are different. And by that time, the family isn't sure what to do if the person can't make his or her own medical decisions. So, yes, always good to update them and make sure that the information is accurate.
Well, okay, I didn't stump you with my hard question. That was a great answer. And I just want to make a few closing remarks. I want to thank Dr. Robinson and all of you for joining us tonight and tell you about the next webinar that the ABF is going to host, which is going to be on June 26th on the signs of Alzheimer's and other dementia with Dr. David Holtzman. And I've heard Dr. David Holtzman speak. He's a real leader in the field of dementia, and I'm sure it's going to be an excellent talk. You can also follow ABF on social media to stay up to date on all the information about brain disease and research that's going on at the ABF. You should also consider visiting the Brain and Life website and listen to the Brain and Life podcast. You may know that Brain and Life is the official publication of ABF's partner organization, the American Academy of Neurology, with information and resources to help you keep your brain healthy. And I think I met Dr. Robinson at Brain and Life meetings. Isn't that correct? And you can also support innovative research to find the cures of tomorrow by making a donation to the ABF. No donation is too small, and all are deeply appreciated. There's no way any of this would be going on without your support. So it's been, I think, a really interesting hour. We don't talk about this topic enough. Thank you again to everybody, and have a good night.